Hello, and thank you for joining me. My name is Dr. Duncan Lascelles. I am a surgeon, small animal surgeon. I specialize in orthopedics, and I split my time between doing clinical orthopedics, running a pain management clinic, and clinical research in the area of pain. I develop ways to measure pain and then use those methods to determine what works to alleviate pain. So all in all, I am very interested in moving forward effective pain management. But in order to do that, I think sometimes you have to understand what you're trying to treat. And that's what we're going to be talking about today. This seminar is going to be focused on OA pain, and I'm going to take you through aspects of the expanding science of OA, pain, and inflammation. Just before we start, I want to let you know about my current disclosures, where I get my research funding from, who I do consulting work for, who sponsors the educational programs I'm involved with, and my investments and employment. This seminar is supported by Zoetis, and the content is consistent with applicable local regulatory authority requirements. So one of the things that we're going to be answering is this question: is OA an inflammatory disease confined to peripheral joints? So just to drill down on that, we're going to be asking the question, is OA an intense inflammatory disease? And then secondly, is the problem confined to peripheral joints? So this chart here shows you the hierarchical arrangement of different types of joint disease. You can see right at the top there is the abbreviation DJD, so degenerative joint disease. So we're looking at the various degenerative joint diseases, and we can divide these into relatively non-inflammatory and inflammatory. And we can maybe even highlight that by outlining those in red that are more inflammatory. So in terms of the inflammatory degenerative joint diseases, we have immune-mediated joint disease, crystallopathies, things like gout, and infective arthropathies. On the left-hand side of the slide, you can see the arthropathies, the degenerative joint disease processes that are termed relatively non-inflammatory, and they include osteoarthritis, as well as traumatically driven joint degeneration. So the first message here is that osteoarthritis is considered a relatively non-inflammatory disease. As you'll see later on, inflammation does play an important part in the pathology and contributes to pain, but overall it is a relatively non-inflammatory disease, which means we also need to think about what other processes are going on in these joints. Now, osteoarthritis is associated with pain, and that's where now we start to get into the second part of the question: is OA a disease that is confined to peripheral joints? And the argument here is going to be that because it's associated with pain, that pain has widespread effects on the body. Before we get to that, let me answer this question for you: how common is osteoarthritis pain? And we're going to look at dogs and then cats. So osteoarthritis pain, now we're talking about the presence of the disease, the organic disease of osteoarthritis, and pain associated with it. When this question is asked, people trip off the answer, well, 20% of all dogs. And actually current evidence suggests that it's nearer 40%. Nearer 40% of all dogs are demonstrating osteoarthritis associated pain. And if you look at how many of those are actually treated, probably only about half of those with OA pain are treated. And remember, I'm talking about osteoarthritis pain. I'm not talking about just the presence of the disease, the organic disease, because remember, it's not always associated with pain. Now, if we change to talking about cats, we've got good data on the prevalence of, at least radiographic prevalence of OA in cats. And it's somewhere between 60 and 90% of all cats have radiographic evidence of OA. And then about 45% of those have clinical signs of OA associated pain. So all in all, About 40% of all cats have measurable clinical signs associated with OA. So now if we summarize this, you can see that in the given dog or cat population at any one time, about 40% of all animals are demonstrating clinical signs associated with osteoarthritis. They have osteoarthritis-associated pain. And that's really what we want to focus on. I did mention that about 60 to 90% of the cat population have osteoarthritis, at least as measured by radiography at any one time. We don't have great data on the prevalence of radiographic OA in dogs. But again, the important aspect here is to understand how prevalent osteoarthritis-associated pain is. And the reason for focusing on that is that pain is the problem. Pain begets more pain. You know, the presence of pain creates more pain, and pain drives deterioration of the whole patient. So we started off with this question, is OA an inflammatory disease confined to peripheral joints? And we've already started to address this. OA is not an intense inflammatory disease. Inflammation plays a role, and we'll come back to that. And the problem cannot be just confined to peripheral joints, because if there's pain associated with it, that pain is driving deterioration of the whole patient. And let me expand on that a little bit more in the next few slides. So I just want to talk about 3 areas where pain creates widespread deterioration of the individual patient. We'll start with musculoskeletal deterioration. I think we can all understand that joint pain in an individual joint is going to lead to decreased limb use. That decreased limb use will result in muscle atrophy. And so we understand musculoskeletal deterioration in the context of an individual limb. But then if you think about it, decreased use of a limb is going to alter the way the body is carried, and it's probably going to decrease movement and mobility in general. And so you can start to appreciate that with that altered body carriage and less mobility than normal, there are going to be deleterious effects on the musculoskeletal system in a more widespread effect. So more widespread effects across the body. So pain has local and widespread deleterious effects on the musculoskeletal system. I mentioned that pain begets more pain. Well, this comes about because pain, if it's so noxious stimuli, essentially, if they're allowed into the system, and they will eventually be perceived as pain, if these noxious stimuli are allowed into the system, they alter the way the system works, creating what has been termed central sensitization. And that state of central sensitization, one, facilitates throughput of signals. So these noxious signals get through the system more easily to be perceived as pain, and central sensitization amplifies these signals. And so a given amount of signal coming in is going to be amplified and result in the perception of more pain. And then one final area I want to just touch on here. We haven't spoken about this much in veterinary medicine, but I think it'll be more prominently discussed in the next few years. And that is the effect of pain on cognitive function and on the affective domains. So pain decreases cognitive function, and pain has adverse effects on the affective domains. I'm talking about things like anxiety and fear. Pain heightens anxiety, pain heightens fear. And then these things feed back to decrease mobility, decrease sleep quality, and those factors then in and of themselves heighten pain. So you've got this sort of positive feedback going on, and the longer we leave pain untreated, the greater increased resistance to treatment. As anyone who has lost muscle mass and tries to regain it will know, it's an uphill struggle to regain that muscle mass. And the same with these other deleterious effects. If we leave them to take hold, it's more difficult to reverse those effects. We can, but it takes longer. The treatment regimes are more complicated in order to reverse those changes. Now, So pain is the problem. In order to effectively treat pain, what we need to do is we need to understand what is going on in the joint. And that goes back to my earlier comments about how I am a clinician. I'm focused on effectively treating pain, but I think sometimes to understand how to do that best, you need to understand what it is. What you need to understand something about the biology of the disease you're trying to treat. So let's just start to talk about the processes going on in the joint. We're talking about osteoarthritis, so there is degradation, and degradation has a positive feedback loop on itself. So as degradation starts, the products of degradation drive further degradation through various processes. And the processes involved in degradation of the joint certainly drive pain and drive inflammation. And you can think of those processes as being driven independently by the degradation. Now, pain and inflammation are related to each other. So I think probably from a clinical perspective, it's good to think of inflammation always contributing to pain. That we don't really have inflammation that doesn't contribute to pain. You'll see an arrow going in the other direction, though. Pain actually drives inflammation. And we're going to touch on that during this seminar. It's the role of nerves, peripheral sensory nerves, in driving inflammation. And then the processes of pain, the neurobiological processes driving pain and the processes driving inflammation probably both contribute to degradation as well. Although those I've illustrated those as smaller arrows because we don't see dramatic effects on joint degradation if we purely treat pain and inflammation. Now, degradation was a prominent part of this slide. I think it's important to say that currently there are no disease-modifying drugs or supplements. So we don't have anything in our toolbox to decrease, to slow down the degradative processes in a clinically meaningful way. Osteoarthritis is relatively non-inflammatory, and there's a lot more than just peripheral inflammation driving pain. I think this slide helps emphasize that. And I just want to go back to inflammation and the role of inflammation in OA. And just illustrate its changing role in this slide. So in red, you'll see an illustration of the contribution of inflammation to pain. And in blue, you'll see the contribution of non-inflammatory pain processes to pain. And what you'll see here in these pictures is we've got a young dog, a middle-aged dog, and an older dog. Now, OA is a young dog disease. It's driven by developmental disease. And early on, relatively speaking, inflammation plays a larger role in pain than it does at later stages. And once you get to the, if you like, the end stage, inflammation is playing a role, but there are other processes that predominate in driving pain forward. So just another illustration of the fact that OA doesn't involve inflammation, but it's not the be-all and end-all, particularly in the latter stages of the disease. Now, when we talk about inflammation, people often talk about flare. They say, well, what about flares? You know, these inflammatory flares. And I think it's worth noting that we're not actually certain what a flare is. It's worsening clinical signs, and it could be worsening inflammation. You know, the OA patient could be moving to a more inflammatory state rather than less inflammatory state for a period of time. But remember, a flare is defined by worsening clinical signs. And so it could be that it is pain, or the pain processes are worsening. If we look to human medicine, there is no consensus in human medicine as how to define a flare. And again, you know, what we don't know is whether it's worsening inflammation or whether other aspects of the condition are becoming worse. So I think, you know, when we talk about flares, we need to think about treating holistically and not just necessarily focusing on inflammation. So now let's drill down a little bit more on the science of osteoarthritis. And what you'll see in this slide is illustrated, if you like, our current accepted understanding. We have some sort of inciter causes damage to the joint. And so in dogs, that is primarily developmental joint disease. In cats, it's less clear what drives that. But we have some sort of inciter with the release of degradatory products, and those have pro-inflammatory properties. As you can see there, we move from a normal synovium to thickened synovium, recruitment of inflammatory cells, and all of these play a role in sensitizing and activating peripheral nerves. And those nerves that are activated contribute to inflammatory processes in the joint through something called neurogenic inflammation. So it's a two-way process here. We've got the processes going on in the joint as a result of degradation that drive pain, drive sensitization and stimulation of those peripheral nerves. And those peripheral nerves are also playing a role in local joint inflammation. And it's changes in the whole nervous system that contribute to pain. So remember, I talked about central sensitization. However, it's the peripheral nerves that drive all those changes. So, you know, we have the changes in the joint. We've heard about central sensitization. You may even have heard about dysfunction of the endogenous analgesic system. So processes in the joint, processes driving central sensitization, processes that decrease the function of the endogenous analgesic system, these all contribute to pain. But I think it's worth remembering that the more active peripheral nerves are, the greater the drive to these other central changes. So yes, in our treatment approaches, which we're going to come back to tomorrow, in our treatment approaches, we do think about how do we reverse these central changes, but we should also need to be focused on minimizing this peripheral drive to these central processes. And part of the drive to peripheral input from the periphery are activated nerves. And these activated nerves, as I've mentioned, play a role in joint inflammation. So an activated nerve or an upregulated nerve releases substances locally, substance P, calcitonin gene-related peptide, and these contribute to inflammation. And again, this is termed neurogenic inflammation. We've known about this for a long time. This process absolutely plays a role in osteoarthritis. And in the next couple of slides, I just want to illustrate what I mean by neurogenic inflammation. And I've drawn a couple of pictures here. So this sort of green thing that looks like tree roots is supposed to illustrate the endings of a nerve in a joint. Remember, a nerve, a sensory nerve in the joint kind of branches out. Where you see the arrow, it says to DRG, that means to the dorsal root ganglion. So that arrow is saying, okay, that's the central nervous system, that's the cell body of this nerve. Okay, so this is a normal nerve. Now, if we activate this nerve in one area, so something in very locally is activating one sensory ending of this nerve, you generate an action potential. And that's what's shown there with that little black arrow. Now that action potential is going to go, as we all understand, is going to go to the central nervous system, to the dorsal root ganglion. Well, the action potential moves along the nerve, away from the periphery, and then it gets to a branch in the nerve. Now it's easy to think, okay, that action potential just keeps going centrally, but actually an action potential doesn't know its left from its right. It doesn't know which way is towards the central nervous system or towards the periphery. So in fact, when an action potential is generated and it gets that fork in the road, it goes both ways. So actually action potentials go back down to other peripheral endings of this nerve. When that happens, you can see there in the little box, that is pulled out and action potential arrives at the end of the nerve, it actually causes activation of that nerve and the release of substances such as substance P, calcitonin gene-related peptide, and these are pro-inflammatory and vasoactive substances. So now what we end up with is, after a peripheral activation, in a very localized peripheral activation of the nerve in one area, we end up with pro-inflammatory processes occurring at other ends of the same nerve. And so this is neurogenic inflammation. It's nerves playing a role in inflammation. And this partly explains why, if you cut yourself in a very localized area, you see an expanded area of redness of inflammation, neurogenic inflammation. Okay, so let's just pause for a moment and recap some of the key points that we have covered. Firstly, osteoarthritis-associated pain is common. We talked about 40% of all cats and dogs have measurable pain associated with the disease of osteoarthritis. We also talked about how osteoarthritis is less inflammatory than other arthropathies. Inflammation does play a role. It's an important component of osteoarthritis and osteoarthritis-associated pain, but we shouldn't be thinking of osteoarthritis as an intense inflammatory arthropathies. And when we think about inflammation, at least from the clinical perspective, I think we should think about inflammation as always contributing to pain and sensitivity. And then we've talked about the fact that peripheral nerves encode pain, and it's pain and therefore peripheral nerves that are the driver of all the other changes. So it's input from the periphery encoded by these sensory nerves that drive all the other changes, and the pain that is perceived are driving the global deleterious changes in our patients. And these activated nerves in this arthritic joint contribute to local inflammation. So we're moving away from thinking of nerves as just picking up information and sending it into the central nervous system. These nerves contribute to those local pathological processes. Okay, so now we're going to move on, and we're going to talk in a little bit more detail about the neurobiology. We're going to talk about what we know already related to prostaglandin E2, and then move on to some other factors. And prostaglandin E2 leads us on to the non-steroidals, because non-steroidals inhibit the production of prostaglandins. And this is how they produce predictable pain relief, the inhibition of prostaglandins. The diagram you see in front of you at the moment just illustrates how prostaglandins are produced. They are produced by the action of cyclooxygenase enzymes on arachidonic acid. And 15, 20 years ago, we had this idea that cyclooxygenase 1 produces useful prostaglandins, cyclooxygenase 2 produces the prostaglandins involved in pain and inflammation. We now know that things are more complicated than that, COX-1, cyclooxygenase 1, produces prostaglandins involved in pain and inflammation. And indeed, COX-2 is producing prostaglandins that are useful. And arachidonic acid can be acted on by lipoxygenase enzymes, producing leukotrienes that are involved in pain and inflammation. So that the picture we now know is more complicated, but that aside, non-steroidals still produce predictable pain relief because whether they're acting on COX-1, COX-2, or a combination, they are inhibiting the production of prostaglandins, including prostaglandins that are involved in pain and inflammation. And I've already mentioned that probably the most important one is prostaglandin E2. And so non-steroidals have this analgesic effect because they inhibit the production of prostaglandin E2, and prostaglandin E2 is sensitizing nerves. So what prostaglandin E2 does is it binds to EP receptors on these peripheral sensory nerves and results in sensitization of those nerves. So prostaglandin E2 doesn't activate nerves, it makes them easier to activate. So it's playing a role in peripheral sensitization. It is one of the nociceptor sensitizers. So injury to tissue, damaged cells and inflammatory cells then produce these nociceptor sensitizers, including prostaglandin E2. Prostaglandin E2 sensitizes nerves, making it easier for nociceptor activators to activate those nerves. So that's what peripheral sensitization is. And prostaglandin E2 plays a really important role in that. And so that's why non-steroidals are predictably efficacious, because in the periphery, they are playing an important role in peripheral sensitization and enhancing transduction of stimuli from the periphery, from the external environment to sensory nerves. Non-steroidals actually also, their predictably efficacious actions are also partly explained by the role of prostaglandins in the spinal cord. Prostaglandins there facilitate processing at the level of the spinal cord. So it's almost sort of regardless of the neurobiology that's driving pain in a particular patient, non-steroidals are going to be predictably efficacious. Now, as we start to think, well, what other systems could we interact with to provide pain relief? There are certainly multiple opportunities for intervention at multiple levels of the pain transmission system, whether we're talking about the periphery, processes in the periphery, whether we're talking about the processes that drive central sensitization, that maintain central sensitization, or whether we're talking about the processes that cause dysfunction of the endogenous analgesic system. So multiple opportunities, but I think one thing to remember is that when we talk about central sensitization and all the processes involved in that, we have to remember those processes are driven, they're initiated and driven and arguably maintained by peripheral input. So I do think it's important to go back to the periphery and say, okay, let's take a closer look at the opportunities for analgesic intervention in the periphery. And there are dozens, there are probably hundreds. This cartoon here illustrates some of the players, the substances that are involved in osteoarthritis and osteoarthritis associated pain in the periphery. And you can see them here: bradykinin, 5-HT, prostaglandins, ATP, hydrogen ions, calcitonin gene-related peptide. All of these are playing roles, but they're not all playing equally important roles. For example, inhibitors to bradykinin have been developed, but clinically they don't make much difference. And that's because there's a lot of redundancy in the system. And in order to clinically make a difference, you have to choose something that is playing an important role. And we know that prostaglandins are playing an important role because we know when we inhibit them, we see clinically meaningful analgesic effects. Another substance that has been realized to be playing an important role over the last, this has been realized over the last 15 to 20 years, is nerve growth factor. I'm going to talk a little bit about that. Nerve growth factor is a neurotrophin, and it mainly acts on a receptor called the TrkA receptor. So let's talk a little bit more about nerve growth factor and its role in these peripheral processes. So nerve growth factor, it is a neurotrophin. It has its effects by binding to this receptor called TrkA and also the P75, but mainly the TrkA receptor. And during development, as you could imagine from its name, nerve growth factor, it aids the normal development of the nervous system. But as we'll see in a moment, in the adult, its primary role is pro-nociceptive. Before we get to that, I do want to acknowledge that nerve growth factor does have beneficial effects in the adult. So in the developing individual, it's important for the normal development of the nervous system. In the adult, it still has protective actions on the survival of peripheral nerve cells. It contributes to the normal function of cholinergic neurons. It's actually involved in fine-tuning of insulin release. Nerve growth factor is expressed by many tissues in the eye, and it has beneficial roles there. And it has potential therapeutic properties on tissue healing, beneficial effects in cardiomyopathy and myocardial ischemia. So nerve growth factor expressed at a basal level does have some important beneficial effects in the adult. But coming back to my earlier comments, its primary role in the adult is pronociceptive in situations where nerve growth factor is overexpressed. And osteoarthritis is one of those. So during the degradative processes, nerve growth factor is produced by a variety of tissues in the degrading joint. This nerve growth factor binds to its receptor track A on the ends of sensory nerves. And what it does then is it changes the function of other channels at the end of that nerve and sensitizes that nerve. And the end result here is very similar to prostaglandin E2. So up until this point, nerve growth factor has sensitized nerves in a way, in an ultimate functional way that is very similar to the effects of prostaglandin E2. This is where then things start to get a little bit different. Nerve growth factor bound to its track A receptor gets retrogradely transported to the cell body, the nucleus of the sensory nerve. So that complex is taken up and along nerves to the dorsal root ganglia. When that complex arrives at the dorsal root ganglia, at the nucleus, it actually increases transcription of neurotransmitters, receptors, and ion channels. And I've listed some of them here. So receptors there, receptor ion channel is the TRPV1, also the acid sensing ion channel 3. Neurotransmitters would be BDNF, brain-derived neurotrophic factor, substance P, calcitonin gene-related peptide. So we've seen this increased transcription of neurotransmitters, of receptors, of ion channels. And as a result of that increased transcription, these are sent in both directions. These new proteins, these new neurotransmitters, these new receptors are sent to the central terminal of the primary afferent and to the peripheral terminal. Those that go to the central terminal are the neurotransmitters. And so we see an increase in the release of neurotransmitters, which means there's enhanced signaling between the primary afferent fiber, the sensory neuron, and the second order neuron. Essentially what that means is that now the signal, the pain signal, is more likely to get through into the central nervous system and up to higher centers where it will be perceived as painful. Also, we get neurotransmitters and pain receptors, if we can call them that, being sent to the periphery. So we have a greater expression of receptors at the periphery that encode pain, and greater release of pro-inflammatory mediators such as substance P and calcitonin gene-related peptide. And remember, that's important because these nerves play a role in neurogenic inflammation. So now this nerve that has been affected by nerve growth factor, when it's contributing to neurogenic inflammation, it's contributing in a greater way because of the increased release of these pro-inflammatory mediators. So to summarize, nerve growth factor alters both the look and the function. You can think of it as phenofunctional changes of the sensory nerve. It causes that sensory nerve to become sensitized, like prostaglandin E2, but it also causes the look and function of that nerve to change. So that nerve is now plays an even greater role in sensing potentially painful stimuli and a greater role in neurogenic inflammation. So that's the nerves, but nerve growth factor also has effects on inflammatory and immune cells. And I drew a little cartoon here to illustrate this. So the nerve growth factor that is released acts on various inflammatory immune cells, activates them so that they produce inflammatory mediators and more nerve growth factor. So now let's bring this full circle. And Now we go back to our original diagram, and we can call this the expanding science of OA pain, because we have what we knew up to this point, and now we just simply superimpose the role of nerve growth factor, which has pro-inflammatory influences, has pro-nociceptive influences, and enhances this process of neurogenic inflammation. And so I think, if we now look at some key points, so prostaglandin E2 facilitates pain by sensitizing nerves. Nerve activators produce pain signals. Non-steroidals produce pain relief by inhibiting the production of prostaglandins. So if you inhibit the production of prostaglandins, you inhibit that sensitization of the nerves so that those nerve activators cannot so easily produce pain signals. And that's kind of where we've been in our understanding. As I've hopefully shown you in this seminar, what we now understand is that nerve growth factor is also a very important player in osteoarthritis pain. It's produced by damaged tissue, it's produced by inflammatory cells, and it's an important modulator of nerve function. Not only does it sensitize nerves, but it also alters the phenotype of the nerve. And remember, go back to my comments, how it's these peripheral nerves that are driving all the other changes in the central changes, the central sensitization, the dysfunction of the endogenous analgesic system. So nerve growth factor is playing a really important role in the peripheral drive to all these other changes, in the peripheral drive to pain. And that's the sensory nerves. Nerve growth factor also activates inflammatory cells, and you have that positive feedback loop. So hopefully I have given you a little bit more information about what is actually going on in the arthritic joint to cause pain. And when we come back tomorrow, we're going to talk about some of the treatments and the expanding treatment toolbox based on our understanding of the neurobiology of what's going on in the arthritic joint. And we'll see how these will then be making a difference to your clinical practice. Thank you for joining me.